Hi guys, this is Jenna Friedenthal, and I am so sorry. I hope that you can all hear me, that you cannot see me, because I like to entertain you with my overly emotive expression. So I'm sorry that you're not seeing my face, and I'm sorry about the technical difficulty. But I don't want to lose any more time because I know everyone's time is precious, and I want to be respectful of that. So you're going to hear my voice and you're going to see my slides. And if you want to see me for an in-person consult, then you can see my face or for a telehealth consult also. So let's get started. Thank you so much for joining. To reiterate, my name is Jenna Friedenthal. I am a reproductive endocrinologist and infertility specialist, double board certified OBGYN and REI here at RMA of New York. And so, as an infertility specialist, I specialize in the diagnosis and management of reproductive disorders, mainly infertility and in fertility preservation, such as egg or embryo freezing. So, just for a little background about me, I completed my undergraduate education at Yale University, and then I went on for my medical degree at the Albert Einstein College of Medicine with distinction in research here in New York. I completed my residency training in OB/GYN at New York University. And finally, I completed my subspecialty training in reproductive endocrinology and infertility here at RMA of New York through the Icahn School of Medicine at Mount Sinai. And this is where I was invited to stay on as faculty, and that is how I am here today. And so I'm really excited to talk to you about all things fertility and fertility preservation. And so, as I said, if it's okay with everyone, I prepared a few slides. And so I think a good place to start is to first talk about what it takes to make a baby, what to expect at your first visit with an REI like me, the diagnostic testing that we can do, and then talk a little bit about fertility preservation, egg freezing, embryo freezing. And I will make sure to leave plenty of time for questions. What I would say is let's use the Q&A box for all the questions. And then as soon as I'm done kind of showing you the slides, I'll go through all the questions one by one, if that sounds good with everybody. All right, so let me share my screen. Um, Give me one moment talking about technical difficulties here. Okay, so I'm just adjusting this, make this look a little bit easier to see. And hopefully everyone can see my slides. If you can't, definitely let me know in the Q&A, okay? All right, so I think moving on. So what does it take to make a baby? Well, there are four basic ingredients really that you need. Number one, you need to have a uterus that is functionally normal, that can house and sustain a pregnancy. Number two, you need fallopian tubes that are open and without any disease, because it's actually in the fallopian tubes that fertilization happens. Number three, you need sperm of sufficient quantity and quality to fertilize an egg. And that is essentially like the four basic ingredients. So in terms of breaking down what might be going on, why you may be having trouble conceiving, it really all starts with the first visit. So what should you expect at the first visit? Well, whether you are a patient trying to conceive or you're somebody interested in egg freezing or embryo freezing, it should be a pretty similar experience at your first visit. So at your initial consult, we go through your complete history, your family history, any medical problems, surgeries in the past, medications that you've been taking, allergies, anything that might affect either your reproductive health or your ability to conceive or our ability to perform an egg freezing cycle, if that's what you're looking to do. And then we perform an exam, and what that exam involves is an ultrasound and an exam of the blood via hormone testing. So with ultrasound, we first look at the uterus. We want to make sure, to know if there's anything structurally abnormal that would need to be removed before, either proceeding with treatment or before trying to conceive, things that can be associated with pregnancy loss or fertility, things like fibroids and polyps. And it's also good to look at the uterus, because sometimes if someone has a large fibroid, which is a benign growth of the muscle wall of the uterus, it can make an egg retrieval challenging for the purposes of egg freezing or IVF. So it's always better to know about challenges up front so that we can kind of plan accordingly. So we look at the uterus first, then we look at the ovaries. And so in addition to looking for any abnormal cysts or structures that could affect reproduction, what we actually do is a count of the number of follicles that we see in each ovary. We call that the antral follicle count. And that gives us a sense of right away your ovarian age. Am I seeing the number of follicles that I expect to see for someone your age? Am I seeing more or am I seeing less? We then also will get blood work looking at all of the basic hormones of reproduction, including your thyroid hormone, prolactin levels, FSH, LH, estrogen levels, and importantly, something called the AMH, or anti-Mullerian hormone. So AMH is a hormone that is made by those small follicles. So you can imagine the more follicles that you have available, the higher your AMH will be, and the fewer follicles you have, the lower your AMH. And I think I should say I use the phrase follicle and egg interchangeably. Eggs are microscopic, so we can't see eggs when we look on ultrasound, but we can see follicles, and follicles are just the fluid bubbles in which eggs grow. So we use follicles as a surrogate marker for eggs when we're looking at ultrasound. And again, I use the phrase follicle and egg interchangeably. And so I think from here, I want to talk about what's a subtle, but it's a very important point. All of the testing that we've talked about so far, the ultrasound, the blood work, this is all quantitative testing about the number of eggs remaining. But none of this testing is actually evaluating egg quality. Because, and I want to say this loud and clear for the people in the back, there really is no test for egg quality. The biggest test, of course, is, when someone decides that they want to get pregnant, how easily or difficult it is for them to conceive. But I commonly see patients who come in for a consult because they went to their gynecologist and they had an AMH level drawn for whatever reason, and maybe it's lower than expected and they're worried. Does that mean I'm infertile? And the answer is no, because we followed women that were ovulating regularly trying to get pregnant, and we looked at their AMH levels to see if there was any relationship, and there is not. And it makes sense logically because AMH is not a marker of egg quality. It's not a reflection of egg quality. So whether your AMH is, 2, 1, 0.1, as long as you are ovulating regularly, you have no reason to assume that your ability to get pregnant with that egg is any worse off than anyone else's with a higher AMH. Now, the other caveat to that, though, is that women who have a lower than expected egg count for their age or a low ovarian reserve, may end up entering menopause a little bit younger than people who have a higher AMH. And it can make it that if and when the time comes that they are getting pregnant, that or trying to get pregnant, I should say, that they're having difficulty, sometimes at that point their egg count is so critically low that I can't offer them treatment like IVF because their egg count is just too low to be able to stimulate the ovaries. And so for those people, although this is not a reflection at all of egg quality or their ability to get pregnant, it may make sense to do something like egg freezing up front before their egg count has gotten critically low. Hopefully that makes sense. And if there are questions and that doesn't make sense, definitely put them into the Q&A and I will get to them as soon as we're done. Okay, so we've gone through all the testing that would happen at your first visit. And in addition, if you're trying to conceive, there are two other tests we would get. The first is, of course, the semen analysis to determine whether any male factor in fertility is present. And the second is called an HSG, which stands for hysterosalpingogram, which is a test to make sure that the fallopian tubes are open and without any disease. But now let's focus on the actual egg freezing process, right? That's really why we're here. So why freeze your eggs? I think that is one of the most important questions to answer tonight. And that's, I think starting here, eggs are like a box of chocolates for those people who know Forrest Gump, and hopefully I'm not aging myself with this. Um, over time, there are fewer and fewer chocolates, and those chocolates go bad, right? So over time, the number of eggs or follicles that we have remaining goes down, and the quality of those remaining eggs also goes down. So quantity and quality are both things that are affected by aging and the passage of time. Again, to remind everybody of the reality of female reproductive aging, the maximum number of eggs that we will actually ever have, or that we'll ever have, is actually before we're ever born. We have our maximum number of eggs when we're approximately 20 weeks old, still fetuses. That's when we have about 6 to 7 million eggs. By the time we're born, we have lost 80% of those eggs and are born with only about 1 to 2 million eggs. By the time we hit puberty, that number drops significantly to about 350,000 eggs. And of those, we will only ovulate 4 to 500 of those eggs. So by the time a woman reaches 30, she has lost 87% of her eggs and 97% of those eggs by age 40. And nothing, not pregnancy, not birth control use, nothing aside from fertility preservation can stop this process. And again, not only does our egg quantity decline with age, but unfortunately, so does the quality. Over time, even if pregnancy occurs, we have higher chances of miscarriage, particularly as we approach our late 30s to early 40s. Age 35, people hear about that a lot in the media. It's relevant not because a normal, pregnancy is impossible after that point, but more that the odds of miscarriage start to go up significantly. So you can see here, this is, a woman's age on the x-axis, and then on the y-axis here is the risk of fetal loss, which is just medical speak for miscarriage. And you can see after age 35, the risk of miscarriage goes up very significantly. Another way of looking at that is this figure here. So this is a figure taken from a study looking at over 15,000 couples that underwent IVF to get pregnant. And the reason they're a good population to study is because with IVF, we can do what's called PGT, which is where we screen the embryos to see which ones are chromosomally normal or not. And so on the x-axis is female age. On the y-axis is the proportion of embryos in each of these age groups that are chromosomally abnormal. We call that aneuploid, will not lead to a healthy live birth. And so I think you can see on the one hand, it's not like you hit age 35 and this immediately jumps to 100% abnormal. So we all know people in their 30s that can get pregnant on their own. But on the other hand, I think you can see the slope of this curve really does start to change, actually realistically around 31, 32. At that age, about 25% of your eggs on average are already abnormal. And it goes up from there. By 34, that jumps up to 30%. By 35, that jumps up to 35%. By 37, that jumps up to 45%. By 38, about 50% of a woman's eggs or embryos are abnormal. And so 38 is a definite critical marker and turning point where now more of your eggs on average are abnormal than normal. By 40, that goes up to about 65%. So you can see how that ratio very quickly flips on its head in the wrong direction, so to speak, as you make your way through your 30s. And this is the data that gives us the understanding of the role of aging on egg and ultimately embryo quality. And so again, there's really nothing that we can do to prevent this effective aging, except for fertility preservation via egg or embryo freezing. So hopefully this is making sense. But again, if there's questions, keep just adding them to the Q&A. So now that we've talked about why to freeze your eggs, I think it's important to understand how egg freezing and fertility testing works. And to do that, I actually think it's important to start with a quick overview of the menstrual cycle, because it's through our understanding of the menstrual cycle that we know how to interpret fertility tests and also how to take advantage of the menstrual cycle for egg freezing. So at the beginning of your menstrual cycle, your ovaries release a certain number of follicles into the visible area of the ovary. Again, I use the phrase follicle and egg interchangeably. And so we can look at these ovaries on ultrasound, and not to totally overshare, but these are actually my ovaries, because yes, I have done ovarian stimulation. I needed IVF, not just egg freezing, but the process is exactly the same. So I can speak what it's like to go through ovarian stimulation on a personal level, if that's helpful for anybody. And so you can see these dark circles here are my follicles. And so you can see the ovaries release a certain number of follicles at the beginning of every month. And from there, your brain sends signal to your ovaries via hormones to pick one of those follicles to be the dominant follicle of the month, the winner, so to speak. All of the other follicles that were there die off on their own. That one follicle ovulates its egg, and if sperm were present, the stars align, right? That egg fertilizes and leads to a pregnancy. And if not, that egg also dies off and the whole cycle resets. So that's the menstrual cycle. Now, why is this important to know for egg freezing? Thinking back as to how egg freezing works, with egg freezing, all we are doing is giving you more of the hormones that your brain is already making. So that instead of all of these small follicles dying off on their own while only one big follicle gets chosen for ovulation, they are all growing nice, big, healthy, mature eggs that instead of ovulating, we retrieve at the time of the egg retrieval and freeze. And so you can see these follicles all look a lot larger than they did a few days ago, right? Again, these are my ovaries after several days of ovarian stimulation, and they're much larger because they're responding to the extra hormones from the brain, telling them all to, instead of die off, to be rescued and lead to healthy, mature eggs that we can retrieve. Okay. So now that we've gone through why to freeze your eggs, we've talked about, what we do at the initial visit, how egg freezing works in general. I thought it would be helpful to just review what it's like on a day-to-day basis so you can get a sense of what to expect if you were to do an egg freezing cycle at RMA. So here it is by the day to day. And again, this is a general template, but as I say, it's like a basic recipe, but then that recipe gets tailored to your individual needs based on your age, based on your ovarian reserve, other underlying medical problems. So take it with a grain of salt. This is a general template or recipe. That being said, most often it starts with day one, and day one is your period. You give us a call. We bring you in then usually a couple of days later, let's say day three of your period to do another check-in with your ultrasound and blood work. And if everything looks good on day three, that is actually when you start the medications. And so you continue with the medications essentially for about a week and a half. In that week and a half, you are coming back in the beginning, like every 2 to 3 days, to repeat monitoring with an ultrasound and with blood work. Last day or two, it tends to be every day just to make sure that we're timing everything really well. And we're open 7 days a week. So we do this on the day that is best for your eggs and for your body, not a day sooner, not a day later. It ultimately then ends in the egg retrieval and culminates in the egg retrieval. So let's talk about the procedure itself. And so here's a little graphic of the procedure. And so basically an egg retrieval, they're done here in the 9th floor of this building, right, one floor below my office. We have an anesthesiologist, so you do go to sleep during an egg retrieval, but it's not general anesthesia. So no tube down the throat to breathe or anything like that. That is all done through the IV, but you're definitely comfortably asleep. It is, as a procedure, basically the same as a transvaginal ultrasound, except that on retrieval day, you're asleep, number one. And then number two, at the end of the ultrasound probe, which is what you can see here. So this is the ultrasound probe sitting in the vaginal canal. At the end of the ultrasound probe, there's a tiny needle that we use with the ultrasound for guidance after your sleep to make one puncture on the right through the vaginal wall and then one puncture through the left. And that is how we access your ovaries and aspirate or suck out the fluid from each of these follicles. And that is how we retrieve the eggs. So everything is done vaginally, nothing is done abdominally, and there are no incisions or cuts or anything like that. It is literally a pinprick, one on each side of the vagina. And so finally, I think this is the sort of nice place to end, and then we can sort of start talking through questions. The question that I think ultimately people end with is, well, what does this mean and how many eggs, depending on how many eggs I have frozen, did I do a good enough job of protecting my fertility? What are the odds of me actually being able to have a baby from the eggs that I had frozen? And so this is the best data that has been published that's available for answering this question. And so on the x-axis is the number of mature eggs, and on the y-axis is the probability of having at least one live birth, broken down by the age at which you froze your eggs. And so, for many of my patients who are 35 and under, they're in this red line here. And as you can see, if someone were to have, let's say, 15 eggs that were frozen, that gives about an 85% probability of having at least one live birth from this process. Now, how one feels about that 85% is where subjectivity comes into play, right? I think a lot of patients are happy with those numbers, but are there other patients who would like to do a second cycle just to really beef up their egg bank, or because they know they want to have 4 or 5 kids? Absolutely, right? I think the other part of it is that we have to work within the confines of someone's ovaries and their ovarian reserve. And somebody who in general has a low egg count, we might not be able to get 15 to 20 eggs in one cycle, right? And that's why that initial consultation with that ultrasound is so important, because it allows us to start to set expectations right away as to how many eggs we might be able to get at the time of the egg retrieval. Okay, so I'm going to stop sharing my screen and I'm going to start looking at the questions. Question number one was, will this be recorded? Will this recording be shared after the session? Yes, I believe it will. And so that'll be sent out to you guys who are logged on here. First question, are AMH levels impacted by birth control? AKA, can someone get this measured and have insight into their fertility when they're on birth control? The answer is you absolutely can have your AMH level tested while you are on birth control. Most of the data shows that AMH is not significantly affected by the use of birth control pills. It can be slightly, But it's not the sort of thing that you're going to go from an AMH of 0.1 to an AMH of 4 when you go off of the birth control pills. It's also not affected by where you are in your menstrual cycle either, which is another common question. So that's why AMH is really great, because it's pretty consistent and steady no matter whether you're on medications or whether you're on a certain part of your cycle, anything like that. What tool do you use to determine changes of successful pregnancy? I think maybe that meant to be like odds of successful pregnancy based on number of eggs. Do you recommend more than one cycle of egg freezing? So I think that harkens to, that was probably asked before we got to that graphic that I showed you guys at the end. And so we use that sort of algorithm for predicting the probability of having a baby based on the number of eggs that you have frozen and the age at which you are when you freeze your eggs. Which meds can you stay on during the egg freezing process? That's a great question. Largely, you can stay on almost all of them. I would say, common ones that people worry about are like ADHD medications and anxiety medications. And I can tell you for egg freezing, you can stay on all of those. The one medication that it is really important to know about that we have you go off of are the semaglutide. So like Ozempic, Zepbound, those type, only because there's a slight risk of anesthesia risk. And so we have you stop the medications just when you start your egg freezing cycle. So you're only off of it for like a week and a half. And as soon as you've had your retrieval, you can literally start back on it that evening or the next day. So that's the main one to keep in mind, when we're thinking about medications during egg freezing. Okay, next question. If you go through with egg freezing, does it decrease the number of eggs for natural conception? No, right? Because all we are doing, again, hearkening back to the menstrual cycle, is taking advantage of what's happening with the menstrual cycle. Your ovaries release follicles every month. No matter what we do, they release follicles every month. And one gets chosen to ovulate, and the others that were released die off. So all we're doing is rescuing follicles that were otherwise destined to die off, and instead growing them and then freezing them. We can't, even if we wanted to, access the full sort of reserve of your eggs and in full reserve of your ovaries. And so by definition, it's not decreasing the number of eggs that you have left for natural conception. Okay, what is the maximum number of egg retrievals that you would be willing to do on one patient for fertility preservation, and how long do you wait in between? To answer the second question first, really, you don't need to wait. There are centers out there that will do something called duo stim, which is where you get your egg retrieval done and you can literally start up with another cycle like a day or two after that. I would say here at RMA, we reserve that type of expedited cycle treatment really for our cancer patients who really have a time set that they have to start their chemo. And so we're just trying to be as efficient as humanly possible with their time. Most of the time, what we do like to do is let you get your period, which usually happens like a week and a half after the retrieval. By definition, when you get your period, your hormones are back down to baseline. And so I think that that's a nice sort of like compromise where we're allowing your body to kind of reset back to baseline. But from there, then you can get started right away with the next cycle. And I have patients who do that pretty frequently, to be honest with you. And they plan in advance that they won't know that they want to do 2 cycles, sometimes egg freezing and then embryo freezing or vice versa. And so you can start again, like a week and a half or 2 weeks after the prior egg retrieval. And there is no like detrimental impact in terms of, number of eggs retrieved, quality of those eggs, things like that. In terms of the max number of egg retrievals, I think the American Society of Reproductive Medicine says that after somewhere around, like 6 to 8 retrievals is when, there should be at least a conversation had about, sort of risks versus benefits and what the goal is and whether or not we've met that goal. So you can do quite a lot. I would say in my practice all these years, I have really only had one patient who's gone above like 5 retrievals. And that was a patient who knew she wanted a very large family and had diminished ovarian reserve. And so she wanted to do, a lot of retrievals, and then was very happy at the end of her 5 retrievals. On the graph where you show probability, yes. The x-axis notes mature oocytes. Is that just the number of eggs you get, or is that the eggs that are mature and survive? So that is the number of mature eggs that you are frozen, meaning that on the day of your egg retrieval, initially the embryologist will just say we have 20 eggs, right? But then they'll go through in detail and look under the microscope morphologically. Eggs can have different maturity. So there are very immature eggs called germinal vesicles. There's metaphase 1 eggs that are of like an intermediate maturity. And then there's the metaphase 2 eggs. Those are the eggs that we use for freezing and that we use for fertilization for IVF. So this is specifically talking about the number of mature oocytes that you have, the number of mature eggs that you get at the time of retrieval. So if you get a phone call saying you had 20 eggs retrieved and of those 16 were mature and frozen, that's what that was talking about on the x-axis. Okay, next question. I've been on birth control for 10 years. Will I have to take a long time to be able to do this? Do I have to stop? The answer is not necessarily, actually. I have many patients who have been on birth control for literally decades, and their ovaries look great and their ovarian reserve is perfect. And we just keep them on the birth control pills until the day that they want to start their egg freezing process. And then they just come off the birth control pills a day, or so before they start the meds. Sometimes the birth control pills, if you've been on them for decades, can make the ovaries look a little artificially suppressed, and make the follicle count look lower than it is in reality. And so if I see that for my patients, I will have them go off the birth control pills just for like a month before they want to get started. But it really doesn't require more time off the birth control pills than that. Okay, what are some things that you recommend for fertility preservation? I'm not sure what I apologize. I don't know. I'm not sure if I understand the question. Like, meaning egg freezing versus embryo freezing, or maybe thinking about things that you can do to optimize your health in anticipation of fertility preservation. If it's the latter, I will say smoking is the number one thing that affects egg quality and quantity. So stopping smoking is the best thing that you can do for the purposes of maximizing your fertility and your egg freezing cycle. There's a lot of data out there and studies trying to look at things like diet and exercise and lifestyle changes. And I will say largely it doesn't show a whole lot. I mean, I think anything that's good for your body is good for your chances of success. So, cutting out processed sugars, following a Mediterranean style diet, that's all good for you. But as I tell my patients, it can be a stressful process. If you need a cupcake on a Friday night to get you through, that's not going to be the thing that affects your egg quality or your egg count. What are an ideal AMH and FSH level for, let's say, for a 31-year-old? I would say for FSH, generally, if the FSH is less than 10 to 13, that for day 3 of your cycle, and I'll say because FSH does vary by where you are in the cycle. So, between days 2 to 3 of your cycle, if your FSH is less than 13, that's considered normal. AMH, there is a wide range of what is considered normal or ideal. But I would say certainly above 1 is considered normal, and above 2 is probably closer to average or ideal, I would say. Do I have to take time off work to do something like this? There are so many visits. So here's the good news. No, none of my patients need to take off work. And that's because those visits happen first thing in the morning. We open at 6:45 in this office. So the goal is for it to be, a 30-minute visit at the top of your day with hopefully as little intrusion into the rest of your workday as humanly possible. So I have many teachers, I have many healthcare workers who need to be at work by 8. They'll come in at 6:45, be the first visits of the day, and they'll be out of there by 7:15 and on with the rest of their life. So it is definitely doable with work. You do not need to take time off of work. What are the side effects during the process? I will say largely not much. Feeling tired, occasional headaches, occasional breast tenderness, that's the most common stuff. And then right around retrieval day, is when you may start to have like some bloating, some cramping, pelvic pressure, fullness, things like that. That can last for a couple of days after the retrieval. That being said, most of my patients do go back to work the next day, but you see how you feel. If you need an extra couple of days off, that's normal too. What vitamins do you recommend taking? CoQ10, vitamin D. I would say before you start taking vitamin D, it's worth it if you think you might be low. The vitamin D level is worth us evaluating and then supplementing as needed, because you can actually have you can like over toxicity with vitamin D. So check your level first and then only treat if it's actually low. CoQ10, and supplements in general, I will say I kind of think of as like the Wild West of medicine, in the sense that there's no FDA oversight. There's nobody regulating what is in supplements, and if they're um, providing what they claim they're providing in the quantity that they claim is being provided without additives like arsenic, mercury, other things that have been found in spot checks of supplements. So I personally am a very less is more when it comes to supplements. That being said, CoQ10 is relatively well studied and is at least certainly safe. And so I will tell patients that if they want to take CoQ10, there's no harm to it. The data is somewhat equivalent in terms of it actually improving egg quality or quantity, but it's certainly not harmful. What is your experience working with people with PCOS? Lots of experience, and not to overshare, but I am also a fellow PCOSer here. So I am very well versed in polycystic ovarian syndrome. PCOS, there's sort of different ways to think about it. There's trying to get pregnant, and then there's fertility preservation. When trying to get pregnant, the biggest issue with women with PCOS is that they don't ovulate in a regular, predictable way. And if you're not ovulating in a regular, predictable way, then number one, it's hard for you to time when you're going to have sex and therefore get pregnant. And number two, if you're not ovulating as frequently as other people, then you're by definition having fewer chances of getting pregnant in a given year. And so if you're just trying to get pregnant, again, depending on what the circumstances are, there are certainly oral medications that we can use to help jumpstart your cycle and have you ovulate in a much more regular, predictable way. And that is very successful for PCOS patients. And then when it comes to fertility preservation, I will say PCOS patients, again, including yours truly, do quite well with PCOS, with egg freezing, because we tend to recruit lots of follicles, lots of eggs. And so one of the silver linings of having PCOS is that you tend to do really well with egg freezing and with IVF and get lots of embryos. What is the cost per cycle? The answer is that that's honestly, I don't want, that's the part that I can't speak to just because everyone's benefits are so different. We really are thankfully in a state where we're able to get a lot of coverage, either with medication and or the procedure itself. So I would say when you see me for a consult, I can have my finance coordinator look at your benefits and give you like a more realistic cost per cycle. What is the difference in success rate between frozen eggs versus frozen embryos? The answer is that once the frozen eggs are turned into embryos, the success rate is identical. The place where there is a difference is in the initial thaw survival rate, meaning what proportion of the eggs or embryos survive the thaw when the time comes that you want to use them. And that's where there's a slight difference. So at RMA, our egg thaw survival rate is about 80 to 90%, which is great. Compare that to our embryo thaw survival rate, that's like 98 to 99%. But that being said, once the egg survives the thaw, fertilizes, etc., the odds of it leading to a live birth are the same. Are eggs that mature later the next day of lesser quality? Nope, not at all. I don't get my period on birth control. How would I start the process or day one start? Easy. Honestly, we just do like what we would call wear and cycle testing, meaning let's say you wanted to start your cycle on June 1st and you go off the birth control pills and you don't have any bleed. I would bring you in June 1st or June 2nd. We'll just check your bloods because for the purposes of fertility preservation, or IVF, when you're doing the ovarian stimulation part of all this, you don't need to have a bleed. Like that's not going to change how many eggs you have frozen. We use the bleed as a marker for when your hormones and your ovaries are at the beginning of your cycle or at their baseline. But women often don't get bleeds when they've been on birth control pills for a long time because the lining of the uterus is really suppressed. Which is fine because it means that your ovaries are probably at their baseline and suppressed too, which is actually the way that you want to start a cycle. You want to start the cycle when all the follicles and the eggs are still small and not one of them has jumped ahead already and taken the lead and about to ovulate. So basically you would just come in and we would do blood testing, and if everything looked good in your blood work, then you could get started right away. What about if you have an IUD? Here's the good news about the IUD. It absolutely can stay in and doesn't affect anything in terms of your cycle because the IUD acts locally. It does not release systemic progesterone. And not to be too nerdy about it, but I was one of the people way back when who published the data showing that you can keep your IUD in, whether it's progesterone or copper IUD, and it does not affect the number of eggs that you have retrieved or anything like that. Again, because it doesn't act systemically. So it's just acting at the level of the uterus and the cervix. So you can absolutely keep it in. We don't want you to get pregnant by accident for no reason. Should you take folic acid when doing egg freezing, or is that just an issue with pregnancy? Just an issue with pregnancy. And then finally, would the initial consultation confirm if someone has PCOS if they don't already know? Yeah, it can. PCOS is sort of what we call like a diagnosis of exclusion, meaning that we do testing to make sure that there's nothing that mimics PCOS that someone may have that was missed. And then if you meet criteria, what we call the Rotterdam criteria, meaning you have very irregular or absent periods, any lab or clinical signs of elevated androgenism, like testosterone is elevated, or you have really severe acne or thinning of the hair on the top of the head, or you have the polycystic appearance of your ovaries on ultrasound, then you meet criteria in the absence of any other diagnosis. And that is definitely something that we, and that I help to confirm all the time in my practice every day. So yes, that is something that we could assist with. Um, how do we find out about the cost? Can we call the office and find out ahead of time, or do we need to make a consultation? The answer is it's never a bad idea to just call the office first and see what information our finance team can give you with your benefits. And a lot of times we can have that information even before you make the initial appointment. But I think, sometimes it can be hard for the finance team if they don't know what you're interested in doing. So I would just be clear and say, I'm interested in egg freezing or embryo freezing, or I've been having trouble getting pregnant. And in the context of that, what do we know in terms of my benefits? It's hard because we don't always know the answer to that in terms of what insurance is willing to cover until we actually what's called like submit an authorization to your insurance company, meaning that we write my note and I write a report to them saying, this patient has had, 9 months of infertility and I recommend that she do IVF. And we submit that paperwork and then we see, really what then the insurance company is willing to cover. But certainly my team can give like a general overview of what they think may be covered and if not, how much it would cost. And it's always worth calling. And then if there's any confusion or if you just want to at least start with diagnostic testing, which is pretty much always covered, then you can make the appointment with me and then see kind of how things are looking from there. Okay. I think that that is all the questions. So I'll hang around for one more minute and then I'll let everyone go. Again, I am so sorry that you can't see me. Not that my face is so delightful or anything, but I think it's nice for you to be able to at least see my face. But you can feel free to look me up on the RMA website. Again, Jenna Friedenthal is my name. And this was so lovely. And yes, this recording, I believe, will be shared with the attendees. So you can always like reference back to this. It was really, really nice. Thank you for hanging in there with me despite the technical difficulties. And thank you for participating with all these really awesome questions. And hopefully I will meet some of you in person for a consultation soon. All right. Bye, guys.